Hi, my name is Daniel Heng, and I'm a medical oncologist at the University of Calgary Tom Baker Cancer Center, and I had the opportunity to attend GU ASCO in San Francisco here in 2018. So I'd like to give you some RCC updates. I think the biggest news here is that of Emotion 151. So Emotion 151 is a first-line metastatic renal cell carcinoma study that randomized patients to first-line atezolizumab plus bevacizumab versus sunitinib, first line. And it showed that there was about a 3-month overall progression-free survival benefit. The overall survival is still immature, but there's a trend towards some overall survival benefit, but it's still immature. I think on independent review of the scans, it showed that maybe that benefit in PFS maybe has decreased a little bit, so that requires some reconciliation. But I think overall, it's very exciting that we might have a new type of therapy for the first line. It makes it a little bit more confusing in terms of what do we do in the first line? There's pazopanib, there's sunitinib, there's ipilimumab plus nivolumab, and now there's potentially bevacizumab plus atezolizumab. What are we going to do and how do we choose them? The bev-atezo combo seems to be very well tolerated, and it doesn't matter if you're IMDC favorable, intermediate, or poor risk, you would still benefit from it. But is it worth the cost? And is that independent review PFS difference being small, is that an issue? I think we'll have to look at pharmacoeconomics, whether or not people can pay for it, and examine the data a little bit more. But I think it's really exciting for patients that there are these choices coming up. So when they become approved, if they become approved, for favorable risk patients, we'll still be using VEGF TKIs, or maybe we could be using bevacizumab plus atezolizumab. For intermediate and poor risk patients, we would try to use ipilimumab plus nivolumab, and we would also have the option of atezolizumab plus bevacizumab. And for those patients that can't have immunotherapies or doublet therapies for reasons of toxicity or cost, then we would stick with VEGF targeted therapy. So I think that's how things are going to evolve in 2018, and there's so much more data coming. It's actually really exciting. The last thing I wanted to talk about is that of cytoreductive nephrectomy. So in cytoreductive nephrectomy, we've shown a lot of retrospective data that there probably is an overall survival benefit. So Jeffrey Graham from Calgary actually looked at cytoreductive nephrectomy in papillary renal cell carcinomas, also showing an overall survival benefit even after adjusting for prognostic factors. So I think the story on cytoreductive nephrectomy is really solidifying. I think really it's becoming a standard of care. People that aren't very, very poor prognosis should probably be considered for a cytoreductive nephrectomy, especially if they have symptoms in their kidney, bleeding in their kidney, but maybe not if their prognosis is super short. So I think there was a lot here in San Francisco, and I look forward to future meetings to see how this evolves, because things are definitely changing quickly.